This is part one of a two-part piece.
TopMedTalk.
Good morning and welcome to EBPOM Online 2020. It's great to be with you here today, coming to you from Durham, North Carolina. And I'm excited to be here today to talk to you about a topic I'm quite passionate about, and that is the role of using perioperative nutrition to optimize our patients' outcomes. And I hope to impress upon you that this is a topic that we can and must do better at providing optimal nutrition care to our patients. And I think the first key piece that I want to leave you with, or the first key message I want to leave you with, is that no malnourished patient should ever have elective surgery without having a nutrition assessment done, and when found to be at nutrition risk, having nutrition therapy or nutrition optimization assured. And what do I mean when I say this? And what happens to patients so often when this doesn't happen, which sadly it's not happening too often. It's something I think we can really improve. Well, to talk about that, I want to tell you about a patient that I took care of not so long ago. And his name was Joshua. He was a 23-year-old young man who had Crohn's disease, and he was presenting for an elective colectomy. He otherwise had been a healthy young man before his disease, and as so many of our inflammatory bowel disease patients do, he'd lost a great deal of weight in the time coming up to this elective surgery as his disease became more difficult to manage. He had a 40-pound weight loss in 3 months, and his BMI was 18. And so the real question is Joshua ready for surgery? Or should his surgery be delayed to address his poor nutrition state? Well, of course, they didn't delay his surgery, and this happens all too often now as well. And he went to surgery, and for the first day or two, Joshua did pretty well. But then towards the end of the second day, he developed a cough and a fever, and he was diagnosed with pneumonia and went on antibiotics, as so often, sadly, is the case after major surgery. But then on the third postoperative day, things got worse. He developed septic shock, DIC, disseminated intravascular coagulation, had a massive abdominal bleed and severe shock. And he was being cared for in a small hospital in the community, and they didn't feel they could care for Joshua there, so they flew him to us at the university, at the big university hospital, where we took Joshua to the OR. We dealt with the bleeding, we addressed the issue, and unfortunately, despite that, he came back to the ICU, which is where I met him as his ICU physician, with an open abdomen and an ARDS from the shock that he had been in. And he went through all the things our critically ill surgical patients go through when they have these complications. And unfortunately, one of those things was also getting poor nutrition, not just before surgery, but after surgery. So again, what does that look like? Well, unfortunately, he had no pre-op assessment or intervention done when he was clearly malnourished. But of course, as it takes so long to start feeding our post-operative surgical patients, he was NPO for 5 days post-op. And that's not because the surgeons caused an ileus, but that's because we know that when you don't feed the stomach for more than 24 hours, it becomes akinetic, and patients vomit when they finally start getting fed, and he did the same. And so that's on us as the caregivers, the postoperative caregivers. So he's off enteral nutrition for 2 more days, and he tolerates about half his needs for the next week. And so we know it takes an act of God to start tube feedings in patients like this after surgery, and it takes the nurse going to lunch, sadly, sometimes to stop them. And so he had his tube feed stopped many times and got very poor nutrition. Despite all of this, he was discharged from the ICU 48 days later, not to home, of course, but to a rehab center, to a long-term care unit. And we as the physicians applaud. We must have succeeded. We got him better. He left the hospital, correct? Was he a success? And what did Joshua think about his care? Well, this is what Joshua told me when I asked him what he thought about how his hospitalization had gone. And he said, I'm glad I'm going home, but I have a few things that I'm really concerned about. And one is I can't feed myself or swallow. I'm too weak. I have to learn how to swallow again because of the weakness and muscle loss I've had. I can't stand, walk, or dress myself because I'm too weak to get out of bed. I've gotten so malnourished and so weak that I'm not strong enough to stand up. But none of these were his number one complaint. Joshua's number one complaint was this: I can't even change the television remote with my hands because I'm too weak. from the malnutrition and muscle loss that I've suffered in my surgery. And so Joshua went to rehab and was diligently doing his exercises and walking in the hall. And I got a phone call from his father about a month later. And I was anxious to hear how Joshua was doing. I'd been caring for him for quite a while. And he said Joshua was out in the hallway walking, trying to get strong again, when suddenly he had chest pain. And a feeling of doom came upon this young 23-year-old man. Moments later, Joshua was found on the floor of the rehab center in cardiac arrest. He gets compressions and CPR for 40 minutes on the floor of the rehab center. And moments later, Joshua was declared dead. What did he die of? He died of a massive pulmonary embolus. He'd gotten a blood clot from immobility in his legs that wasn't detected. And so what happened to this young man? It was devastating. He should have lived, right? He was 23 years old. We treated his inflammatory bowel disease. We treated his sepsis. We got him through the ICU. What did he really die of? He died of this. He died of this right in front of me and us, and I'll never forget it. It was truly that nutrition was neglected and was an emergency for this patient. So we have to be better. We have to be better than this at addressing something that seemingly should be simple to address. But how can we do that? And perhaps first, how common is this? What's the prevalence of malnutrition amongst our surgical patients we're caring for? Well, we know that 65% of our patients undergoing GI surgery, which many of us care for, are malnourished before they get to us, and they don't improve their nutrition under our care, sadly. They almost all get worse after their surgery induces the catabolism it does and the poor feeding they face. Is it related to outcome? Well, we know it is. We know that if you come into a major oncology surgery, major cancer surgery, and you haven't lost weight, and you're well nourished, your mortality is very low. You should do very well. But if you have lost weight, your mortality goes up 5-fold. Complications the same. If you haven't lost weight and you're well nourished coming into your surgery, you should get through without a complication. If you have lost weight, you're going to have a complication. And this affects many different kinds of complications. You can see all of the complications we care a lot about in the hospital: pneumonias, catheter infections, mediastinitis, Clostridium difficile. They all are increased by patients who have malnutrition. In fact, one in particular, intravascular catheter device infections, so central line infections, go up 16-fold in malnourished patients versus non-malnourished patients in certain surgeries. This is a dramatic effect malnutrition has. And in fact, although not the perfect nutrition marker, but a really good marker of overall nutrition status, perhaps to start with, before surgery, not after surgery, albumin, when it is low, predicts mortality exquisitely well in the surgery. And this is from now the over 2 million patient NSQIP database. In fact, malnutrition or having a low albumin at the time of surgery is the number 4 predictor of death within 30 days of any big operation, any major inpatient elective operation. So again, if you look closely at this list, not only is it a major predictor, but it's the only modifiable risk factor that we can do something about in the weeks before surgery. So it's a real opportunity for us to change outcome for our patients like Joshua. And the reason we don't talk more about it is because the mortality that happens after surgery for malnutrition happens after the patients leave us. We don't see the mortalities and some of the severe complications that malnourished patients have. As you can see, the malnourished patients tend to die months after surgery. They leave the hospital much like Joshua did. But unfortunately, Joshua only survived a month, and many of these patients suffer mortality very shortly after hospitalization as well. So I'd advocate to you, this is an emergency for our patients, and we have to be better. But how do we do that? And so the real question is, how many of you have had surgery? And if you haven't, if you're not raising your hand, you will. Everyone will undergo 9.2 surgeries in their lifetime. And so the real question becomes, can we improve this experience and these outcomes for our patients and ourselves someday as we face major surgery? Well, I don't need to ask this audience what ERAS is, but I do think it's important to realize ERAS encompasses many things, including nutrition. And I think we all know ERAS is pretty awesome. But nobody does awesome better than these people. So I'm going to let them tell you about the role of nutrition in ERAS. Listen closely.
Wait, you forgot to sign. Oh.
Why are you guys going so fast?
Beep, beep. We're on the fast track. Woo!
Wait!
Hey, why are those guys going so fast? And what's fast track?
Oh, you must mean fast track surgery. We call it ERAS.
ERAS?
Yeah, it stands for Enhanced Recovery After Surgery.
So what's the deal with it?
Well, let me tell you about it. ERAS is a program designed to help people recover more easily from surgery. So normally, before any type of bowel surgery, we would stop patients from eating and give them a strong laxative.
Yeah, that's what I had. I was starving and had diarrhea.
Yep, it makes you pretty dehydrated.
Those pesky residents come around every morning asking if I had pooped.
Hey, Dan, have you pooped?
No.
It's been a week after my surgery, and I still haven't pooped.
Thanks for sharing that, Janie. So let's look at what happens in the new ERAS program. We're changing what we do before, during, and after surgery. They can eat real food up until 8 hours before the surgery.
So I can have supper the night before the surgery?
Yeah, of course. As long as it's just a light meal. No donaires or anything crazy like that. And you can even drink some juice on the morning of the surgery, up to 3 hours before go time.
Cool. Awesome.
ERAS is so awesome. ERAS is so cool and you can't get it free. And ERAS is so awesome when we don't need IVs.
3, 2, 1, go.
Have you heard the news? Everyone's talking. Post up is good because everyone's walking. Hand operation, but recovery's faster. Limit narcotics like a master. I realize ERAS is passing gas. I'm eating all the food and I easily pass. 2 days later, beating the forecast, feeling like a boss. ERAS is awesome. Stepped out of my bed, grabbed my skateboard. It's awesome to move. It's awesome to poop. It's awesome to poop. It's awesome to poop.
ERAS is so awesome. ERAS is so cool and you can't get it free. And ERAS is so awesome when we don't need IVs.
Hopefully, you're now convinced it's as awesome as I think it is. And the reality is with ERAS, our hope is we can maybe even improve functional status from where patients started. The idea that we can actually optimize patients. And of course, ERAS involves many things that are targeted to optimize patients before, during, and after surgery. And nutrition is key to all of these. Now, there's many challenging parts of ERAS, as we all know, and you think the nutrition part should be the easiest part, right? So everyone's getting their nutrition addressed before and after surgery. This is my youngest child when he was 3. His nutrition needs are quite readily addressed. In fact, he'll make sure that he can do it himself. But my patients, not so much, sadly. And our patients, this is just not getting done. And so again, we have to be better, but how do we do that? And one of the ways is we make guidelines. And I had the opportunity to work with many of the names that you know and many people that you recognize on this panel at the POCI US Surgical Guidelines, the POCI 2, where I chair the surgical nutrition guidelines and got to work with lots of wonderful experts to help us do this. And we published these recently, and I think there's some key take-home points for all of you to help think about this for your patients. The first is, as we said, 2 out of 3 major GI surgery patients are malnourished when they come to us. And the risk of mortality is 5-fold higher in those patients than if they had their nutrition addressed. Sadly, only 1 in 5 major hospitals, these are university hospitals now, have a formal nutrition screening process for these major operations. Although almost all the surgeons we've polled in our surveys think that if we treated malnutrition before surgery, we'd improve outcomes. And we know that the simple treatments, the nutrition drinks, the protein oral nutrition supplements, for every dollar you spend on those, you save $52 in hospital costs. There's few things that are cost effective, but only 1 out of 5 malnourished patients are ever getting these. So this gives us a chance to do things better. And how do we do that? We have a POCI Nutrition 6. These are the simple things you can do to improve your patients. First, pre-op and post-op nutrition screening is essential. If you don't look for it, you won't know it's there. Protein's more important than calories and getting those in. Stop feeding late pre-op and restart feeding early post-op. Consider oral nutrition supplements for all patients before and after surgery, especially after surgery. Oral before enteral, before parenteral, and nutrition management's a team game. You need your dietitians and your nurses and everybody to be on board. So what do our statements say, and what are some key points we can take away from those statements to improve our patients' care? So let's talk about a patient briefly, another patient things. This is Michelle. She's a 63-year-old with colon cancer coming for colectomy. her nutritional background. She's got a BMI of 18, a weight of 50 kilos. She's lost 6 kilos because of the colon cancer and the bellyache she's had, and her albumin is low. So her nutrition evaluation needs to be simplified and be able to be done rapidly in your clinics. And so we've tried to create a situation or a system like this at Duke called the POET Nutrition Concept, or the Preoperative Enhancement Nutrition Clinic Concept. And this is a concept where we screen all 60,000 of the Duke surgery patients by phone with some basic malnutrition questions that I'll show you in a minute. We're doing it in our bone marrow transplant patients as well. And then we have a continuum of care that starts with this nutrition screen on the phone. We have a nutrition clinic within our pre-op clinic now that's run by an RD. We have an inpatient team that's transitioned the care to, and then we have a post follow-up period with this RD in this nutrition clinic who follows our major surgery patients at risk for malnutrition. So this is the system we've put in place to deal with this. And to score these patients quickly, we've built this perioperative nutrition screen into our electronic medical record. And this is what it looks like. Simple questions. Is your BMI low? Have you lost weight without trying? Weight loss is really key here. Have you been eating half of what you usually do, or is your albumin less than 3? If the answer is yes to any of these questions, they need to see a dietitian. They need nutrition intervention. And so how do we treat them? Well, if they're a low-risk patient, we still want to address their nutrition, but we do a few different things. We give them immunonutrition 7 days before and a carb load the morning of surgery, and then immunonutrition 7 days after and a high-protein H&B ONS for 4 weeks. If they screen in for malnutrition, we give them a high-protein H&B containing oral nutrition supplement for 4 weeks, then a week of pre-op carb load, a week of immunonutrition followed by a carb load, and then another week of immunonutrition after surgery followed by 4 more weeks of a high-protein H&B supplement. And then we have our RD follow our malnourished patients. So what about Michelle? Well, she is the highest risk. She scored points on all of the key questions. She had a risk score of 4. So the other way we are beginning to assess for malnutrition that's perhaps even more objective than those questions is using the CT scan to measure lean body mass. We know that taking the L3 cut, we can trace out the lean body mass, the skeletal muscles in red there, and we can assess sarcopenia, which we are showing ties to nutritional risk and surgical risk. This is just one example. So patients who have sarcopenia coming from Whipple surgery have significantly higher mortality over time than patients who don't, and this is true in many types of surgery. Can we do better even than this at the bedside, perhaps, and even monitor our nutrition delivery using tools we already have? Well, we can, and one of those is the ultrasound. Muscle ultrasound is something my group has published a great deal on, and others have as well, and we're beginning to do more routinely at Duke as well. And we ultrasound the leg, sometimes the temporal muscle, and we can get a lot of information now with a muscle-specific ultrasound product that's come out that is built to measure the muscle on your leg or your temporalis in minutes. It's a probe like this big that plugs into your iPhone or iPad, and it gives you wonderful images like this that reads out muscle mass, muscle glycogen, and muscle quality, and it gives you reports that you can follow on your patients. So we're excited to use this technology to diagnose malnutrition in the future. So how to treat Michelle's malnutrition? Well, the first thing we would say is you need to achieve protein intake first, more important than calories. And that we recommend a goal of 1.2 grams per kilo per day or more minimum. Protein is vital. You can't build a house without bricks, and protein is fundamental to maintaining muscle and maintaining the immune response to surgery. These are the goals we should be achieving, 1.2 to 2 grams per kilo per day. These are based on nutrition guidelines that have been around for years. And I think as our patients are aging, this is becoming even more important because as our patients age, they become more anabolic resistant. It takes more grams of protein to build one, say, unit of muscle when you're older than it did when you were younger. So the older we get, the more protein we have to take in to build muscle, and that's anabolic resistance. Now, not everyone loses muscle as they age. This is a 70-year-old bodybuilder who clearly shows you don't have to lose muscle mass. He does a few more things than just eat well to do that, but nonetheless, it shows you that you don't have to lose muscle mass with aging, and we can learn from people like this. We know that taking protein in as boluses is probably more ideal, and encouraging our patients to do that is probably the best. And taking in branch chains and leucine at night before we go to bed has been shown to increase lean body mass 15 to 20% in the elderly who aren't even exercising. So taking in branch chains at night is a good thing to do, and then it has to be combined with preoperative strength training and exercise, which is a whole nother lecture for another day. But when we become surgically or critically ill, it's even more dramatic, our need for protein. We have more severe anabolic resistance, and it's likely other interventions like the H&B I've mentioned, or even anabolic agents like oxandrolone or testosterone may be required to recover and prepare for surgery optimally. And this post-ICU and post-surgical dysfunction is real. We know that large numbers of patients, up to 40% of our major surgery patients, have significant physical impairment following their surgeries. And these are things we can address before and after surgery with nutrition. Because the question we need to ask ourselves when we operate on older and older patients is, are we creating survivors or are we creating victims? And the reality is, as we think back on patients like Joshua, even a young patient, are there things we could have done to prevent his post-surgical infection? And we would advocate there are. This is one of our recommendations. We recommend patients at major nutrition risk, like Joshua, receive immunonutrition or high-protein ONS, like you saw me describe, for at least 7 days before their surgery. This is just one of many papers showing that benefit. 800 gastric cancer patients who were malnourished, who received optimal pre-op nutrition, most of it oral, had a reduced risk of surgical site infection by 2.5-fold versus those patients who didn't have their malnutrition treated. So again, just one of many trials. And again, when you can't get oral nutrition supplements or enteral nutrition in, if you can't feed the gut, we strongly recommend preoperative parenteral nutrition. It's one of the grade A recommendations in all nutrition guidelines. We have very good data for this. And then the question always comes up, well, doesn't TPN increase the risk of infection, especially in sicker patients like ICU or surgical patients? The reality is the data is overwhelmingly no. So what you were taught in medical school is not true anymore. And this has been published in some big journals you've probably heard of: New England Journal, Lancet, JAMA. 4 large randomized trials of many, many patients in many, many centers show that TPN does not increase infection risk in any way in 2020. And in fact, it's just as safe, it looks like, to put TPN through the line as it is to put saline through a line. It's not what's flowing through the line that matters, it's good central line care that matters. Then the next piece, of course, is pre-operative nutrition. We suggest that this should be considered for all major elective abdominal surgeries. The data for this goes back many years and is very strong. And it shows that we can reduce infection risk 40% in our patients if we use just even a week of these simple, inexpensive supplements. How does this work? Well, we know that arginine malnutrition is induced by trauma, physical trauma to the body. The body depletes arginine, and that impairs our immune system and our immune response to surgery. This is part of our evolutionary code. It's not related to malnutrition. If any of you had surgery, no matter how well nourished you are, your body would do this to turn off the immune response. This has evolved in our bodies since cavemen to shut down the immune response after a few days, because if you didn't get up off the ground, you died. You didn't have a trauma surgeon waiting for you, and so the body had to keep your immune system from killing you. But now, a few days after surgery, we want your body to respond to infection. We do have surgeons and anesthesiologists that save us. And what's the clinical data for giving arginine back? Well, this is one of the meta-analyses. It's one my group published. 32 trials, 3,200 patients, reduced infectious complications 40% from these simple and inexpensive supplements. Reduced length of stay almost 2 days in the patients who received them. Again, many, many trials, some in very high impact journals, 40% reduction of infections. You can never look at them all, there's so many. And this works if you give this before surgery only, before and after surgery, or after surgery only. The data is very strong. So the key messages here is just give this to your patients, because it works in GI surgical patients, cardiothoracic patients, ENT patients. And now there's larger meta-analyses in big, well-known journals, Annals of Surgery, 74 studies, 7,000 patients, reduces all kinds of complications, including mortality. And I can't emphasize enough, this happens in all major surgery patients, not just malnourished patients. This was a very high impact, well-done trial showing that in well-nourished patients only, this reduced infection risk just as much as the other studies in malnourished patients. So this is not due to malnutrition, this is all patients. Your mother, your brother, your sister, or you having surgery would benefit from this.
TopMedTalk. Thanks for listening to TopMedTalk. We are excited to announce the World Congress of Perioperative Medicine happening in London this year. Check it out at ebpom.org. It will take you through to our carbon-free conference center where it has the EBPOM platform. You can find more information. Be sure to subscribe to TopMedTalk and EBPOM at ebpom.org.